PT on Ice Daily Show. I am Dr. Lindsay Huey, lead faculty for extremity management, and I am psyched to be with you today. I believe we are now live with Facebook and Instagram. Say hi if you're up with me this morning. I am coming to you from Lewis, Delaware, which is a couple hours away from my home in Delaware with the fam, and we're at the beach for a few days. My favorite place to be on earth is near the ocean. So you'll see a different background than usual behind me. Today, I want to speak with you about a near and dear topic to my heart, and that we really dive deep in extremity management on. And so the title of today is "A Picture is Worth 1,000 Words." And in this case, all the wrong ones. And so I can't wait to dive deep in what this means and the topic of MRIs and knee pain. But before I do, let me tell you a little bit about what's coming up in our ICE world. So we have 3 live courses happening this weekend. So if you're on the fence of should I go to a course, I think you should do it. There are 2 courses in California. We have one in Santa Rosa, that's cervical spine management with Jeff Moore, and then we have lumbar spine in Simi Valley, and then clinical management of a fitness athlete this weekend as well in Bear, Delaware. So I'm super psyched to have Gmo and Mitch come to my home gym, Bear Fitness, and talk all things fitness management. So if you live in Maryland, New Jersey, New York, or Philly and want to take a short drive, come to this course. We're going to have a blast. And check out PT on Ice for any of our online courses as well. And we have lots of courses throughout the summer. Extremity management will start again offering courses in later summer, early fall. So I would love to see you at a course. So back to today's topic. So a picture is worth 1,000 words, and in this case, all the wrong ones. So that adage of a picture is worth 1,000 words, it exemplifies how one simple image can conjure up complex ideas, feelings, and emotions. You know, that perfect picture shot of a family or of the ocean, of the mountains. We can all relate to just this great feeling that it can create inside. Conversely, there are pictures, of horror, of war that can create angst and sadness and fear just with that one picture. Well, one MRI image, and while they take a series of images, just one of those can create and conjure up emotion and a sequela of medical intervention through just one report of the findings found in that image. The findings have the power and potential to change a human trajectory through one MRI. It often can provide a false and worrisome narrative for those with an insidious onset knee pain. And often there's this laundry list of words that talk about the abnormalities in someone's knee. Now we know an MRI has a valuable place in some cases, right? With acute injury, let's say a pec tear, or acute ankle sprain, where we really need to find out about the integrity of those structures and if surgery is warranted. There is a time and a place for MRI that's very appropriate. But think about that human that just has insidious onset of knee pain or a flare-up in their knee symptoms, and they get this MRI early. So they get the x-ray, they find bone on bone, and then they go to the MRI and they find this long list. And they see this image that the doc puts up on the screen. It can embody a ton of worry about what's the next step, fear of worsening. They see this image and they think, oh my goodness, my knee is irreparable. What's next? And then any angst that can come about from seeing this image concerning the financial burden of the sequela of possibly needing injections and or surgery. I want to pause before I dive deeper, and I want you to really think about this person. Think about Sally in your clinic, age 45, She's told by her doc that the knee looks really bad. And while they were in there, her knee that she's coming in for pain, they also decided to take a look at the other knee. And they found there is this laundry list of cartilage defect and meniscal tear, and there's a Baker's cyst, and there's this laundry list. And the patient hears this list, and really there's a lot of fear there. And that doctor puts this thought virus in, Sally, I'm going to do my best to ward off surgery, but you're probably going to need a knee replacement for sure in the next 10 years. And that other knee that's not even in pain looks pretty bad too and has similar findings. So they come into your clinic with that thought virus. What inspired me to dive deep is we all see this patient time and time again in our clinic. In addition, Alex Germano from our management of the older adult faculty, TA, she had a similar case like this where her friend who was doing high intensity workouts and yoga had a little knee pain flare up one day, and she got an x-ray, was told it was bone on bone, and then wanted to go right to that MRI, and then found this laundry list of findings, and then didn't want to do any of her activity anymore. And so Alex was like, Lindsay, can you please do a post or a talk on MRI findings? Just recently, in February 2020, Horga et al. Out of the Skeletal Radiology Journal found, after imaging 230 asymptomatic knees, 97% of these subjects who had no previous knee injury, no pain or dysfunction, had abnormality in their knees. So let me repeat that again. A human without knee pain or dysfunction or complaint, there were 97% of those knees that had some kind of abnormality found on MRI. Those specific findings, the laundry list goes like this. So out of the 230 knees, 30% had meniscal injury, 62% had cartilage abnormality, 52% had bone marrow edema-like lesions, 46% tendon abnormality, 38% ligamentous abnormality, 3% joint effusion, grade 2 and 3. Other findings were 33% had Baker's cyst, 26% had prepatellar bursitis, 23% hophosynovitis, 20% ganglion cysts, and 6% some kind of pes anserine irritation. So this long laundry list of things found in asymptomatic, pain-free knees. So let's unpack some of the details of this study a little bit to see if this kind of relates to your patient population. So this is powerful evidence that what we find on MRI doesn't correlate to patients' pain symptoms. 230 knees. So there was actually 115 subjects, and so they MRI'd both knees. These subjects were recruited based on being sedentary, meaning they didn't meet physical activity guidelines of that 30 minutes of moderate activity 5 days a week, or 20 minutes of high intensity 3 days a week. These humans averaged anywhere from 0 to 4 hours a week of activity with a mean of 2 hours, so about 120 minutes a week. So they're not meeting those guidelines even 50%. The average was a BMI of 25, so when we're thinking about this population and kind of their overall health, they were 25 and above with a range of 19.6 to 38.1. All of these subjects had no history of injury or surgery, which I mentioned earlier, and so they based this information off of them filling out the knee injury and outcome scores, and mean scores of all subjects were greater than 90. So this is pretty significant to have all of these findings in subjects that have no pain at all. When we think about the age range, it was a median age of 44, with a range of subjects from 25 to 73. And there was a solid mix of males and females, 51 males, 64 females. So a pretty good span of that patient population that we see in outpatient orthopedics. One interesting finding and possibly limiting factor to population generalizability for you all is that 95% of the subjects were white. So this was a London-based study, so they were Welsh, English, Scottish, or Northern Irish, British. So keep that in mind when you're thinking about your patient population. But despite this limitation, these findings are powerful, and they really reflect what other literature has found in different areas of the body, like the spine, the shoulder, the hip, and that with increasing age, greater than 40, you're going to find pathoanatomic abnormality, which may or may not be associated with symptoms. This is one of the larger studies in the knee, 230 knees. And it's impactful because these patients had no pain, no dysfunction, no previous injury. And it really provides further evidence that correlating clinical symptom to an image is not reflective of reality or a patient's experience. And so this is tough, right, for the MSK team, including the radiologist, the physical therapist, the doctor, because it does put us at a disadvantage to correlate clinical symptoms with imaging findings. The MRI is supposed to be that gold standard. Dare I say this claim, but correlating MRI findings to knee pain, this insidious onset knee pain, right, or a kind of an acute flare-up with no mechanism of injury in that 40 to 70-year range, having the MRI and trying to correlate the clinical symptoms is malpractice. It's time to stop using the MRI as a diagnostic tool, but rather use it as a reference of possibility of correlation. Let's start using the human as the primary reference for symptomatology. One other interesting thing about this study is this was done with a 3.0 T MRI, which is shown to have superior sensitivity as compared to what's commonly used, that 1.5 T MRI. With this higher sensitivity, there's greater ability to detect intra-articular pathology. And it also allows you to see structures more sensitively, more clear picture. But I would argue that while this was out of the skeletal radiology journal where they would boast this as a positive thing, I think this potentially causes more harm when we're trying to see pathoanatomical findings. It allows us to see more. I know I boasted a big claim of malpractice using the MRI to correlate knee pain symptoms. And I know that'll offend some, but malpractice in its simplest form is negligence or incompetence. When we speak about the MRI, we have a responsibility to say that most of these findings are normal age-related changes, and we're missing that piece. Instead, we're talking about the laundry list of what's going on in the knee and creating a sentence of dysfunction and disability for our patients. If your language, and you as the PT are responsible for this as well, because often you're spending the most time with your patient, right? You have that ability to explain those findings. Sometimes the doc just hands the report, talks briefly about what's going on, try PT, but we're probably going to need surgery. That's the message they're given often. And so you have to bridge the gap. And so your language needs to reflect hope and reality. And so if your language of that imaging report causes someone to jump into a surgery that's unnecessary, you have caused harm. This is malpractice. If the language of a doctor or radiologist has caused a patient now to limit their function and activity level based solely on an image and based solely on words related to that image, this is causing harm. This is malpractice. This is negligence and incompetence in its purest form when the patient has come to you for help and hope, and you've elicited worsening pain and function. So what's the solution? The team, the MSK team, the radiologist, the doctor, the PT, you all listening out here today, we need to promote abnormal is normal, and that your patient's pain and dysfunction can be helped with conservative care. That's us, that's PTs. Let's acknowledge that the MRI is not enough to describe a complex, living, breathing, emotional, spiritual human being. It's one piece of the puzzle. It's not that center or corner piece. It's one piece. Let's promote words that heal and that don't cause harm. Let's provide context that with increasing age, there's increasing abnormality. And let's tell them that laundry list to expect. That these findings also increase when you have increased BMI. So it's an opportunity to talk about what fitness forward living is all about, right? With that higher BMI, there's going to be more abnormality on board. Let's help patients rewrite their narrative of an image. And this can be really tough because first you really have to understand the patient's relationship to that image, right? Is this something that they've been kind of carrying with them for years? That bone on bone, that meniscal tear, that there's no cartilage left, and you really have to acknowledge the relationship there and dive deep into understanding that. And then we have to provide that explanation and understanding that a lot of this is related to normal age-related change, that arthritis and fraying didn't just creep up overnight. We need to rewrite and reframe the narrative of the image and the words that are on that report. And we have to focus on controlling the controllables. And those are diet, sleep, hydration, meeting your protein intake, meeting physical activity guidelines. Help your patient learn to control their ecosystem. We cannot change that pathoanatomy on the image, but we can help influence the ecosystem through stress management techniques like mindfulness and getting more rest on board and creating an ecosystem of healing. The other thing that we do really well is do a thorough exam that respects irritability. And so if we can focus on those findings, we'll help our patients reduce their pain and restore function and achieve their goal. Practical solutions. What can we do as the PT to help reduce this message or this narrative of the MRI? Let's encourage our patients to hold off on that MRI as long as you can. If they're eager for that MRI, explain what they're likely to find and probably that it's unnecessary. For that patient that's headed towards the MRI, talk to them about findings that are likely and to not be worried about them, that a lot of them are normal. And when the patient comes in with that MRI report and they're just gung-ho for you to look at it and to talk to them about it, I often will ask the patient, let's wait to review this MRI until after the eval, if that's okay with you. I'll say, Sally, I really want to get a good understanding of your pain and how it reacts to movement. The MRI is just one piece of the puzzle of you not moving. It doesn't give me that clearest picture to understanding you and your body's response to movement. And that's my job to figure out, obviously while respecting irritability. Action items. Use human-focused explanation and framing that helps your patient de-identify with the image and that restores autonomy of a patient's story to them. Help them learn to control the controllables, control their narrative where they're the star in ameliorating their symptoms, not a surgery, not an injection. Help the patient control the things about their ecosystem like restoration of motion, strength, and cardiorespiratory fitness. Be a wordsmith that creates healing and an empowering narrative about that MRI. Thank you for listening this morning. I hope you have a very happy Tuesday.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.